Hello, this is Dr. Nina Kim from the University of Washington. Today I will be discussing hepatitis B reactivation. In this mini lecture, I will review why this clinical event is important to know and avoid, and touch on HBV virology and pathogenesis in understanding this. We'll talk about what happens as HBV reactivation unfolds. We'll discuss who's at risk and what factors in the host as well as in the clinical scenario contribute to risk. And I will talk briefly on antiviral prophylaxis. And finally, we will tie these concepts together in a case example. At the heart of this matter is the persistent nature of hepatitis B infection. In this depiction of the viral life cycle, you can see that the virus, upon entering the liver cell and eventually the nucleus, integrates itself into the host genome. And in doing so, the virus establishes itself through covalently closed circular DNA as a template for viral expression. In other words, an individual who has been exposed to the virus remains at risk, even after resolution of acute infection, of having recurrent expression of the virus with the loss of immune control. And why HBV reactivation remains even more relevant today is because of the growing array of biologic agents, specifically monoclonal antibodies targeting various aspects of our immune system, some of which have been shown to increase the risk of HBV reactivation. So what happens in HBV reactivation? For this portion of the talk, I will be referring to hepatitis B serologic markers. To familiarize yourself with these, please review the mini lecture on this topic on our Hep B Online site or our YouTube channel. HBV reactivation occurs primarily in two main groups of individuals: those with chronic hepatitis B infection, who are surface antigen as well as core antibody positive. In these individuals, a 2-log or 100-fold rise in HBV viral level above baseline, or a viral level that rises 1,000 IU per mil or greater from previously undetectable level, or an HBV viral level of 10,000 IU per mil in someone without prior testing counts as HBV reactivation. The second group are those who have previously been infected and recovered. They are generally surface antigen negative, but core antibody positive. In these individuals, any detectable HBV DNA or the reappearance of surface antigen is enough to count as HBV reactivation. These viral changes are generally accompanied by a hepatitis flare, which is defined as a serum alanine aminotransferase, or ALT level, increase of 3-fold or more greater from baseline, or greater than 100. The first event in HBV reactivation is the rise of the viral level, shown here in green, followed by evidence of liver inflammation or a rise in serum ALT in magenta. You can see that the rise in liver enzymes can be brisk and severe, with ALT that can exceed 5,000 IU per liter. These changes can progress to jaundice and acute liver injury and further into liver failure. And that is why it is important for everyone to recognize HBV reactivation, because at its worst, it can cause significant morbidity when it progresses to acute liver failure, and it can be fatal if not recognized promptly. So who is at risk for HBV reactivation? So there are a variety of clinical scenarios where HBV reactivation can occur. The first 3 settings, chemotherapy, treatment for autoimmune diseases, solid organ or bone marrow transplantation, are scenarios that involve immunosuppression of some kind, and these are the more common scenarios that I will be addressing today. The last 4 are special circumstances where HBV can reactivate that I will not be addressing in my talk, but these are worth noting. So the first step in considering an individual's risk of HBV reactivation involves evaluating their HBV status, but also their intended immunosuppressive therapy. And when we consider these therapies, we can group them as low, moderate, or high risk for HBV reactivation with probabilities as shown here. Therapies with the highest risk of HBV reactivation include B-cell depleting monoclonal antibodies that target the CD20 receptor of B lymphocytes. These are used commonly for the treatment of lymphoma or autoimmune conditions such as multiple sclerosis. Anthracycline derivatives, a class of chemotherapy that includes doxorubicin and epirubicin, are also associated with high HBV reactivation risk. Chronic or high-dose steroids, typically those that are on the order of 20 milligrams of prednisone or more daily for a month or more, count in this list as well, along with tumor necrosis factor alpha inhibitors that are more potent, such as infliximab or adalimumab. Of these, rituximab deserves special mention. This and similar agents carry a particularly high risk of HBV reactivation in both patients who have chronic infection as well as those who have resolved their infection. It was through increasing reports of HBV reactivation with these agents that we learned the key role B cells have in the control of HBV infection. The risk of HBV reactivation is serious enough to warrant a black box warning for this complication for these agents, and anyone who uses these medications needs to be aware of this risk. Therapies with moderate risk for HBV reactivation include a variety of different agents, such as other systemic chemo not previously mentioned, the less potent TNF-alpha inhibitors, tyrosine kinase inhibitors, steroids that are low dose in patients who have chronic HBV, and medium dose for those who have resolved infection. This list are agents that are associated with low risk of HBV reactivation. So how does one keep track of these therapies? You don't need to, because you can always consult these categories again. But it is important to know this list by heart, especially if you use these medications with any regularity. So who should receive antiviral prophylaxis? This table provides the general guidance on the decision to start antiviral therapy or prophylaxis versus monitoring, taking the HBV status as well as the risk level of the therapy into account. It is worth noting that the American Gastroenterology Association emphasizes that if the patient with chronic hepatitis B meets clinical criteria to start antiviral therapy based on their disease status, for example, the patient has cirrhosis, or perhaps they have persistently elevated liver enzymes and HBV DNA level, then treatment should start for their hepatitis B regardless of the risk level of the intended immunosuppressive therapy. What we use for prophylactic antiviral therapy is the same as what we use for oral treatment of hepatitis B, and that is tenofovir as either formulation or entecavir. Lamivudine is not recommended for much of the same reason it's not recommended for treatment, since the threshold for viral resistance and breakthrough is low. And duration is generally for the time that the patient is undergoing the immunosuppressive therapy out to at least 6 months after the therapy has ended. Extended out to at least 12 months, I generally err on 18 months after B-cell depleting therapy. So let's run through a case. This is a 50-year-old woman with a long-standing history of multiple sclerosis with gait instability who has a recent diagnosis of optic neuritis. Her neurologist is considering ocrelizumab. She has hypertension, type 2 diabetes, and no obvious HBV risk factors. So which of the following would you do next? Start ocrelizumab with quarterly hepatic function panel testing, send hepatitis B surface antigen, send hepatitis B core antibody, or assess HBV status with triple test panel. The answer is D, that you would send the triple test panel that includes the surface antigen, core antibody, and surface antibody. You need all three results to fully characterize a patient's HBV status. So her hepatitis B panel shows a positive core antibody and a negative surface antigen and surface antibody. So which of the following would you do next? A, start ocrelizumab with quarterly monitoring. B, start entecavir 0.5 mg once daily for HBV prophylaxis. Or C, start ocrelizumab and monitor for clinical symptoms. Or D, send hepatitis B E antigen and E antibody. The answer is B, to treat. And the reason we treat is because ocrelizumab is a B-cell depleting monoclonal antibody with high risk of HBV reactivation. So that regardless of whether you are a chronic carrier or someone with core antibody but negative surface antigen, the recommendation is to treat. For a deeper dive into hepatitis B reactivation, please check out our lesson on the Hepatitis B website, which reviews in greater detail the clinical decision-making and guidelines.
The production of this Hepatitis B online mini-lecture was supported by funding from the Centers for Disease Control and Prevention.